Very good evening, sir. We are right now live.
Okay. Good evening, madam. Thank you so much. And a warm welcome to all. This is Dr. Chandramohan, physiotherapist from Exercise Testing and Prescription Organization. And we have more than 650 participants from different parts of the world. And today we are having fascia and non-specific lower pain as a topic. And we have our resource person, Dr. Ajimsha. About Dr. Ajimsha, Dr. Ajimsha M S is a young and enthusiastic rehabilitation research specialist from Qatar. He is well known as a clinical expert, professional leader, academician, and researcher on fascia science, neurorehabilitation, and critical care. Following his postgraduate degree in neurophysiotherapy and master's in healthcare, he has obtained consecutive doctoral degrees in neurorehabilitation, myofascial mobilizations, and in osteopathy from India, UK, and Spain, respectively. He has more than 30 indexed journal publications and almost double the number of conference proceedings under his name. Dr. Ajimsha have a very strong passion towards fascia and fascial mobilization practice. His high-quality RCTs on MFR, interventions on tension-type headache, lateral epicondylitis, low back pain, plantar fasciitis, etc., are still considered as the groundbreaking studies in the fascial clinical science. His systematic reviews and critical appraisals on fascial mobilizations helps tons of fascial researchers to streamline their works more with evidence-based framework. His presentations at 5th International Fascia Research Congress held in Germany on improving the quality of myofascial mobilization, research and practice have received much appreciation and reviews. Currently, Dr. Ajimsha focuses more on the role of fascial mobilization on chronic pain and demystifying the fascial myths by gathering and analyzing the available data from across the globe. Dr. Ajimsha has received various awards for his contribution to fascia-oriented research and neurorehabilitation. He was the opening keynote speaker of recent World Fascia Congress 2021, SARS-CoV-2 Rehab Conference, and Qatar International Geriatric Conference and Middle East Forum for Quality Care. We wish Dr. Ajimsha M S all the very best in his future endeavors, and also we welcome Dr. Ajimsha. Welcome, sir.
Thank you. It was a long introduction. Thank you for
happy to have you here. And apart from this, I would like to tell during the registration itself, I received calls from senior most physiotherapists like ex-principals of college, and recently from HODs of few colleges. They are telling that oh, is it Dr. Ajimsha? I have gone through a lot of articles. Oh, this is Ajimsha. I last spoke to him 7 years ago. Maybe he may forgot me. He helped me because his papers related to MFR are strong ones. Only one person in India had released so many publications in MFR. Like that, I have received so many calls and so many messages. So happy to have you here, sir.
Yeah, thank you. Thank you for the timing. Actually, I used to be a closed speaker. I never been open. This is the first time I'm going to be open. I'm going to be in YouTube, basically. So, thank you for the opportunity for making it open. I believe that now virtual medium is the media, for expressing and reviewing and making people more interested and all. So regarding ExRxIndia, I only have very short relation with them. But last time when they have conducted the geriatric conference, actually that was immediately after my Qatar International Geriatric Conference. I felt such a pleasure that they have conducted such a high quality conference, virtual conference. Actually, the topics were so amazing. So and then I thought, okay, these are the guys. Maybe I can keep my opening shots directly into them. So thank you for the chance, and hope that many of my students I will be attending this one, maybe hearing that one, and the number is going slowly up. So we will be presenting about the fascia in 2 days. It will be around 90 minutes today and 90 minutes tomorrow. Today now we will be explaining something more on the fascia and its anatomical aspects. Tomorrow we'll be seeing what we can do based on the logical analysis, how we can design the exercises, how we have to, follow up through the fascial based concepts of exercise prescription. So I'm just sharing my screen.
Yes, sir. I welcome Ms. Duna also to help you.
Yeah. Ms. Duna was actually the, all and all. I just
Yes, sir.
of the
99% of ExRxIndia handled by her.
Okay, the backbone you can say, right?
Yes, sir.
Okay, let me share my.
Yes, sir. Thank you.
I think it's visible for you, right? The screen.
Yes, sir. Yes.
Yes, sir.
Okay, so I put the topic. I put the topic as fascia and the non-specific low back pain, a derivation of a novel clinical practice model. Why I put it as a derivation of a novel clinical practice model is very simple. The 2 days of presentation will make you think that, this is the way I have to arrange my fascial knowledge. Okay, so that's why I put it as a derivation of a novel clinical practice model. I am not going to give you what exactly you have to do. I'll be giving you some pathways, some directions where you will be moving with your clinical reasoning to find out the best optimized treatment, what you can give to your patients. So if any doubts, meanwhile, just put in a paper and we can have a lot of time used in the end of the presentation, either today or tomorrow, to explain these things in detail. Okay. So this is our by law default, nothing to disclose. So what we'll be learning on these 2 days will be first just having a glimpses of pathophysiology of the fascia relevant to clinical practice with emphasis on the evaluation of the fascial science. Then we may discuss about the recent updates on the fascial innovations and its role on the musculoskeletal dysfunction. Then enlisting and explain the fascia as the autonomic afferent system. Now this is the hot topic. Fascia contains a lot of autonomic fibers. Now we are focusing on this one. That is why when fascia is having some problems, you are having more generalized effects. So science are changing every year by means of finding new and new mysterious findings, to be honest. Explain the derivation of a novel clinical practice model based on the recent fascial knowledge, and introducing the basic practice principles of fascial mobilization in non-specific low back pain. Even I'm mentioning about non-specific low back pain, the methodologies and functions, everything will be applicable to most of the musculoskeletal or chronic pain conditions. So this presentation is not for explaining what is a fascia is. It is, I'm wearing a coat, I'm wearing a t-shirt, and I'm wearing different type of dresses. So fascia is like a continuous structure covering all around the body, starting from the cellular level, the muscle fibers, nerves, veins, arteries, muscles, bones, cartilages, everything is surrounded and protected by fascia, and it is a single structure. So what does it, a single structure means? Any change in the pulling, any change in the tension elsewhere of the body can be transmitted, can be propagated to the different parts of the body, because fascia covers everything and fascia is a continuous structure. Normally we used to say that fascia is having 3 layers: superficial fascia, which is very superficial, is immediately near behind the skin, followed by a superficial adipose tissue. After that you can see the deep fascia. Actually, the deep fascias, 2 types are there: aponeurotic fascia and epimysial fascia. Aponeurotic fascia, you can say it's like a sheet-like, okay, sheet-like fascia. For example, thoracolumbar fascia is an aponeurotic fascia. The function is actually controlling the movement, giving informations like proprioceptive inputs. Epimysial fascia is the one, endomysium, perimysium, epimysium, you might have heard about. So the fascia which covers the muscles, a bulk, we used to call it as epimysial fascia. For example, gluteal fascia. Gluteal fascia is an example for epimysial fascia. So most of the epimysial fascia, the functions are coordination and nociceptive inputs. Okay, that is why most of the epimysial fascia, if not having a proper coordination and optimal gliding develops trigger points. You won't get that much trigger points in your thoracolumbar fascia. So that is why we are calling deep fascia can be divided as aponeurotic fascia and epimysial fascia. The third one is visceral fascia. It is actually the one which is covering the internal organs. It can be peritoneum, it can be pericardium. Okay, so there are different things that is actually protects and suspends the organs inside the body. So that is why visceral manipulation also actually a facial technique. So most of the techniques what actually we are using in our day-to-day life as a physiotherapist, as an exercise specialist, whatever, is actually is touching through the fascia. It's not isolatable and it's not separatable. Okay. And if you want to know more about types of fascia, as I mentioned, we are having limited time. So if you are typing the YouTube session 4 types of fascia, you will directly get into one of my old video, which is simply I'm saying about types of fascia. So what are the differences? What is the histology? How much it is the difference? All sort of things as you will get. Session 4 types of fascia. Okay. What I want to say before going into deep or into depth of the presentation is fascia is a very huge organ starting from the cellular level covering all around the body. But don't think that approaching fascia means all about myofascial release or myofascial manipulation. It is one among the 1,000 tools the facial scientist or facial therapist can use. Okay. So I just want to say that never ever say that fascia means myofascial release means fascia. Even the myofascial release word itself is misnaming, you know, it's like a surgical technique. If you're telling to your surgeon, I have done myofascial release for back pain. Oh, as a physiotherapist, you are having the ability to do many things. So release is actually traditionally a surgical word, but no, unfortunately, we started using this one. So I prefer myofascial mobilization is the better word rather than using myofascial release. Okay, so when we are thinking about the fascia, it's like an elephant in the room, and you are a blinded person. You are holding the tusk, you are holding the ear, a leg, and saying that different parties are different. Actually, nothing. It's the same. Just as a refresher, when we are telling about fascia, it is having 3 structures. First is actually cells. Under the cells, you are having fibroblast, myofibroblast, fasciacytes, and telocytes. Fibroblast is the mother of the fascia. Okay. Like in the bee, there is a female bee that is the one producing all the bees and all like that. Fibroblast is the one producing all the fiber cells and everything. So it is the mother cell of the fascia, fibroblast. Sometimes the fibroblast goes for some types of contractile properties with some smooth muscle type of behavior, especially in pathological conditions. Then it is called myofibroblast. That means myofibroblast in the normal condition exist very less in number, very, very less in number. But in pathological condition like chronic fibrosis and all, you can see that the fibroblast will convert into myofibroblast. One of the advantage of fibroblast is it can convert into any type of these cells. And fasciacytes, a recent invention by the Steckhorn team, they find that the hyaluronic acid, one of the glycosaminoglycans that is actually helping the fascia to glide, is actually produced by a modified fibroblast, and that modified fibroblast is called fasciacytes. So just in your understanding, fibroblast is the mother cells which produces almost everything in the fascia. Myofibroblast is actually fibroblast with contractile properties which exist very rarely. Fasciacytes is another modification of the fibroblast that produces hyaluronic acid or hyaluronone, okay, HA. And the telocytes are long tissues or cells or modified fibroblasts which are very long, which functions as conductive media or messengers from one area of the fascia to another area. So telocytes, you can see when you are learning about cardiology, you will be knowing more about the telocytes. Actually, among the cardiac muscles, since it is works as a functional syncytium, as a single unit, herocytes are the one connecting all the muscular part of the pericardium and the heart. So these are the 4 types of cells. And extracellular matrix, when you are in the fascia, when you're taking out all the cells, what remaining is called extracellular matrix. Okay, and this contains fibers, hyaluronic acid, or we can say glycosaminoglycans, proteins, different types of proteins. That is the best way to understand what is glycosaminoglycans, different types of proteins, and water. Of course, every things in our body, 70% is water. So extracellular matrix means fibers and glycosaminoglycans, mainly hyaluronic acid and water. So 2 types of fibers are there, collagen and elastin. Collagen 1 and 3 are the most abundant number of fibers are collagen 1 and 3, and elastin is also there, which gives that resilience or elastic type of behavior. The third component, which recently added or having importance, is nerve elements. Recent studies are saying that fascia contains a lot of free nerve endings, a lot. I'll show you that details in our coming presentations. So free nerve endings, especially 3 and 4, encapsulated, non-capsulated or non-myelinated nerve endings. Pacini and Ruffini. Initially, many of the studies say that fascia used to have a lot of Pacini and Ruffini, but nowadays the studies of histological studies are finding that the Pacini and Ruffini, that is the encapsulated nerve endings, are lesser than what we expected earlier. So most of our functions from the fascia is coming through the free nerve endings. And of course, muscle spindles and the Golgi tendon organ. When muscle spindle stretches, it activates the muscle to contract, right? And the most important point, as I mentioned, the muscle is covered by the epimysium, muscle fasciculus is covered by the perimysium, muscle fiber is covered by the endomysium. And interestingly, the muscle spindle of the outer, like for example, this is the fascia and this is my muscle. The muscle spindles of the outer muscle fibers are actually embedded in the fascia. So the outer covering of the muscle spindles are embedded in the fascia. That means when there is an incoordination between the muscle fibers and fascia, muscle fiber will contract, fascia will stay there. For example, if fascia stiffness is there. So what will happen? The muscle spindle will undergo continuous stretch. When the muscle fiber undergoes continuous stretch because of the fascial stiffness, this causes a lot of calcium, like a tetany type of muscle contraction. There will be influx of the calcium. This causes more glutamate into that area, neurogenic inflammation, pain, trigger point, more pain, more area is affected. Life goes like that. Okay. So the mechanism of pain and musculoskeletal pain, especially the muscular pain, what's so-called muscular pain, now it is myofascial pain, is well understood nowadays. The same thing functions with the Golgi tendon organ when reciprocal relaxation is concerned. And so you can see an additional component, post-ganglionic sympathetic fibers. Now we found that the fascia contains 40% of the post-ganglionic sympathetic fibers. You can say that fascia is an autonomic organ. So anything happens to the fascia will affect the whole body, including the heart rate, breathing capacity, blood pressure, sweating, functions of the internal functioning, your mood, everything will be affected if fascia is affected. Okay, so it is not a small area of study that the fascia now where it stands. And when we are telling about facial anatomy, we used to understand about the cells and extracellular matrix. We'll study about the hyaluronic acid. Why hyaluronic acid is important is hyaluronic acid, when it in the smaller form, okay, it is not segregated. For example, when there is facial dysfunction, hyaluronic acid goes for a segregation, then it is not a hydrophilic one. It cannot attract water. The smallest form, it can attract water. When water is there in between the fascial layers, it can slide nicely. So if I am reaching out my hand like this is my fascia. It has to come along with the muscles and muscle fibers like this. So how it happens is different layers of fascia actually moves over one another. So that is happening because of water in between, and the water will be kept by the hyaluronic acid. When you are not moving, or after a fracture, you have immobilized your part, what will happen is the hyaluronic acid undergoes segregation. It cannot attract water, so that there will be dehydration and stiffness, more stiffness. Then the muscle spindle will get trapped there. There will be incoordination. There will be trigger point formation. Blah blah. Life goes in that way. Okay. Then the importance of exteroception, proprioception, interoception. Exteroception is the touch and outer feelings. What you are having, the feeling from outside the skin is called exteroception. Proprioception, anything that you are having the feeling that I am moving my extremities, I am nodding my head, or I am having some sort of, like a leg. When I am walking, I can feel that I am standing in the air. Everything is done by the proprioception. And proprioceptive fibers are more myelinated, well qualified nerves traditionally in anatomy. Interoception is actually a combination. It's a combo, we can say. Interoception is a modified proprioception. When you feel that your stomach is upset, or you felt that, okay, now your stomach is full after eating, or when you feel that you are feeling hot flushes, all sort of internal feelings are actually called interoception. And we don't know actually exactly which are the nerves working on this area until we couldn't be able to identify the fascial system. Once fascial system we started identifying, we started getting the understanding more about the interoceptions. And the fascia receptors, amazingly, fascia is having a lot of receptors, especially sex hormone receptors, estrogen, progesterone, then cannabinoids. Now we understood that when opioids are taken, why it is affecting very fast and why it is giving generalized pain relief is because of opioid receptors, cannabinoid receptors in the fascia. The same thing happens when the estrogen is there. Females during the estrogen producing style of the menstrual cycle, they are more extensible or more flexible than the next phase, because estrogen is having more representation on the facial receptors. So it can adhere and it can produce more resilience on the fascia. And macro means facial connectivity. Tomorrow we'll explain about the fascial connectivity. Actually, fascia is a continuous structure, so we can connect each and everything. So, for example, when you are having headache, you can relieve the headache by even treating your leg, because fascia is a continuous structure. And force transmission. When it is a continuous structure, it can even transmit force. So facial, myofascial force transmission is one of the hot topic nowadays. World are recent, and a lot of studies. Actually, we itself found around 19 studies. Now it is 36 studies altogether. We found that is actually explaining more about myofascial force transmission. And the sliding relationship with muscles, joints, and the ligaments, that we'll be explaining it later. So this is our area of focus nowadays: innovation, facial remodeling. Okay, whatever we say, fascia and its scientific journey in 1980s. So I was 1980 means I just born that year. So 1980s, it was passive massage, passive. Myofascial release terminology was not there, but it is like something like a massage therapy, something like that. Then it came viscoelasticity, piezoelectricity, hysteresis, thixotrophy in 1980s to 2005. People started explaining a lot of theories, which is actually difficult for us even to understand. In 2005 to 2015, things were a bit more clearer. They could be able to isolate fibroblasts. They could be able to identify hyaluronic acid. They used to be able to identify the properties of extracellular matrix. So our understanding about the fascia becomes more clear. And in 2016 until now, it's like more neural, biomechanical, hormonal, and emotional. Last word I use is emotional. Since fascia contains autonomic nervous system, your emotions can control fascia. That is why fibromyalgia is having pain, sometimes very high. Back pain, when you are under stress, the back pain will be more. It's because of the emotional component and neurobehavioral components. So what we can say is actually In the earlier stages of 1980s, it is theories. Now it is more into emerging evidences. But the point is actually the fascial research is still in its childhood, and the role of fascia is still as an iceberg. We don't know anything about, we know only glimpses. That's also, we don't have much about human studies, very limited amount of human studies. Most of them are cadaveric and animal studies. So our area, our scope of research is very, very high and vast in the facial area. Coming into the facts, we all know that in the sports field, people used to say he got a strain, he got a sprain, he got a muscle injury. Nobody will say that he got a myofascial injury. Nobody used to say that he got a myotendinous injury. So Wilke et al. In 2019 done a systematic review and meta-analysis of the prevalence of extramuscular connective tissue lesions in muscle strain injuries. So most interesting finding they found is actually, 68.4% of all the injuries they have identified from the studies were myotendinous lesions. Then 32.1% of all the injuries were myofascial lesions. Only 12.7% were isolated muscular lesions. Okay, so we can say that among all the soft tissue injuries, only 12.7% was actually called isolated muscular lesions. Rest all percentage were more on the fascial side injury. So injury was more prominent on the fascia, or maybe a facial mechanism was the main reason for most of the strains or strain injuries. Still, if you are thinking that all the injuries are muscle injuries, I don't have any answer about this one. You know, in football players always get hamstring injuries. One of the most common injuries in football is hamstring injuries. And a study in 2019 found that, 90% of all the hamstring injuries which are serious were preceded by another small incidence of pains and dysfunctions anywhere in our body. You got it? Before a bigger, most of the time, before a bigger hamstring injury, or that is needs a hospitalization treatment, there will be some signs and symptoms. Body will show that he'll be having sometimes a dull ache in the hamstring. Maybe he'll have a pain in the calf muscle. Maybe he's having morning plantar fasciitis last week. Maybe he had a back pain the week before that, but we ignore. And 33% of these prior problems are non-focal. That means if we know that these type of signs and symptoms or warning signs, you have to understand that his muscular connectivity or the myofascial connectivity, which the hamstring also a part of, is under compromise. If you are going to play with high performance activities, that will end up with a muscular injury. See how things are connected nowadays, right? Nowadays, we are thinking about non-specific low back pain. Most of the musculoskeletal therapists are actually concentrate more on the non-specific low back pain. What is non-specific low back pain? The pain of back pain without any proven reason like IVDP or facet joint lock or something. There is nothing to find out, but the patient will be having pain. The patient will be having a dull or non-specific pain most of the time, especially when sitting for a longer time, walking for a longer time, under stress, and many reasons. Okay, so any innovative structure in the lumbar spine can cause symptoms. And the nowadays studies are saying even 88% are the, what we can say that non-specific back pains. I think you are following me. Anybody? Just maybe Dr. Chandramohan can say if you can send a message so that he can tell me if anything you are feeling that you cannot understand. Okay, I'm trying my level best to explain the scenarios.
Yes, sir. I'm following
Yes.
through YouTube, and yes, sir.
Okay, thank you. So some of the scientists who got some hypertonic salines, when they were alone, started injecting the hypertonic saline into the back. Not for funny things. It was a study, actually, I'm telling. So they have injected into the muscle of the back rectus spinae. They have injected on the subcutis, the skin of the back, and they have injected on the fascia, thoracolumbar fascia of the back. You know what happened? When they injected the hypertonic saline on the thoracolumbar fascia, it created the maximum pain, and the pain was actually mimicking the typical non-specific back pain. So if I'm this one, for example, subcutis, you can see the skin area, it was producing. The red means the main pain area, another is the dull aching area. When it is in the fascia, see the pain is the main pain and the dull leg pain is increasing. Even he is feeling pain on the lateral side of the body. When the injection was on the muscle, it was very minimal. And the point was actually, when the injection was on the fascia, the stinging, heavy and burning, exhausting feeling is actually the typical when the patient is used to explain when they are having non-specific back pain. And the other point is actually when somebody is having back pain, chronic back pain, the fascia loses its flexibility or sliding capacity almost around, it loses 20%. We used to call it as shear strain. When we are using ultrasound elastography, we used to say that the amount of the fascia to glide or the stiffness will be represented by the shear strain. So any chronic back pain patient, if you are observing their fascia, it is more stiffer, less flexible, and it producing more stiffness for the back. Most of the non-specific back pain patient used to say that their back is like a stiff road, right? Okay. You know about the trabeculae in the bone. For example, when you are an active exercise in a young age, if you are looking at the bone, you can see there will be trabeculae formation. The trabeculae formation is nothing but the connective tissue deposits, which reinforces the bone so that the bone can bear more and more strength. You know, in martial arts and all, they used to break bricks and all with their forearms and all. How they can do is, because of the continuous practice, there will be more and more deposition of the connective tissues along the bones like the trabecular system. So it will be super strong. It will be very stiff and super strong. Okay. So same thing, like the bone, even the fascia will be having the same type of trabeculations. That also will be based on your activities. For example, a strong person who used to do martial arts, running, jumping, cross-fit trainings and all, the fascia looks like this. There will be different layers of something is like perpendicular, something is horizontal. So multiple layers of different types of connective tissue arrangements will be there, so that you will be having a fascia, even it is extensible, but it will be strong. Got it? So fascia will be strengthened and reinforced by the amount of connective tissue which is deposited on it, and the amount will be directly proportional to the activity, intensity and diversity of the activity. That's why I'm showing some pictures here. Intensity and diversity of the activity. So we can say that fascial strength, fascial elasticity, everything is activity dependent. Okay. And when you are young, of course, when you are young, you will be more active. You will be jumping, climbing the trees, running a lot, okay, playing a lot, playing football and all. Your fascia will be like a spring. What does it mean like a spring? That means the resilience will be very high. You know, the volleyball players, they can jump very, very high. Actually, the jump power is a cumulative effect of muscular and facial resilience actually. So when you are young, when you are active, your fascial structure is highly resilient, springy, and there is an angle which you used to call as a crimp angle, which produces a lot of energy to jump or produce something. When you are getting older, less moving, or after a fracture, your fascia looks like this. See how it's a difference. This is a person who is active. You can see the crimp angle so that it is packing the energy there. You know, ninja warriors, they used to jump very high here and all. So they practice in such a way that their fascia becomes so resilient, so energetic, they can store the energy in the fascia. That is why they can even jump higher like the cats and all. But when you are older, or you are having, you know, where is my casa? Yeah. Where you are having more, what say that older, or you are having a fracture immobilized, your fascia undergoes cross ringes, or the facial connectivities and the connective tissue alignments and everything will be go in a different way. And see, there is a complete absence of the creep back. That means this fascia is less efficient, easily tiring, and there will be high chances of injury. And this picture, what it denotes is that this person is pulling the airplane with his teeth. So his strength is as important as that the strength or rigidity or stiffness of the rope. The fascia is the rope. You should have a system that is capable of transmitting the force which is produced to the muscles into the effector organ. So fascia is very important. This is a ninja warrior. They are so trained in such a way that their fascia is compacted with energy, is full of energy basically. Let's go back to the next slide. Okay. I hope that you are understanding what I mean. Okay, so this is a first thoracolumbar structure. See, this OL means outer layer. IL means inner layer. ML means middle layer. See, the outer layer and inner layer are so thin. This is the muscle. Okay, so this is the skin. Outer layer and inner layer are so thin. Middle layer is so thick. And I want to tell that the middle layer is actually the one which is gliding to get the range of movement when you are bending, when you are turning. Okay, and the outer and inner are security guards. That means their function is to detect how much you are moving. What does it mean? The outer and inner layer contains a lot of free nerve endings. See this picture? A lot of free nerve endings, which is interconnected rhomboidus like a structure, like a network. So if you are stretching, the networks of nerves will get stretched. You will get a feeling that, oh, so the proprioception from the thoracolumbar fascia comes from the rhomboidus structure of the free nerve endings, which is present in the outer and inner layer of the thoracolumbar fascia. And see, there are a lot of free nerve endings with the beaded structure. That's actually the nerve endings which produces, releases the neurotropic factors and as when it is necessary. Okay, so the most important point is actually, so this is the skin. Okay, skin is here. This is skin. So skin contains around 65% of the free nerve endings when you stained it. And the outer layer contains 72% of nerve endings. And the middle layer, there is no nerve ending, 0%. And inner layer, 33.3%. That means in the Mense et al. In 2011 and 2019 say that fascia contains a lot of nerve fibers, 43% are sensory nerve fibers. 17% motor, actually the motor fibers are the motor nerves traveling through the fascia. We used to say the intensity when we'll cut 1 centimeter or 2 centimeter square of fascia, then we'll start after staining the fascia, we start counting how many nerves are there. Or we will start the density of the nerves, how that we are calculating it. So we found 43% of the sensory fibers, which are type 3 and type 4 afferent fibers, and vasomotor fibers, 40% vasomotor fibers. That's what I told. Fascia is an autonomic organ, not a motor organ. Motor part is only 17%. That is actually the nerves which is traveling through it, going to the adjacent muscles or something like that. So 43% of the sensory is acting against 40% of the vasomotor. That means any pain in the fascia, the response will be autonomic system response. So that is what our body is created. Why the body is created like that, maybe the future will tell us. So the point is actually whenever there is an inflammation happens in the fascia, it immediately undergoes neurogenic inflammation. What is neurogenic inflammation? When there is an inflammation, the nerve endings will start releasing neurotropic factors or neurogenic factors, nerve growth factors, glutamates, substance P, and all sort of things, so that there will be more inflammation. Okay, so what they found is actually when, see this picture, when the fascia is inflamed, the outer layer, there is more sensory fibers or 4 fibers. Inner layer, there is no, this is actually, I think, PGP fibers, substance P fiber. Substance P fiber means nociceptive fibers. When they have analyzed the fascia before and after producing inflammation, they found that after inflammation, there is a huge amount of increase of nociceptive fibers. That means nociceptive fibers is the pain fibers, the fibers which modified into pain-taking fibers. And altogether, you can see that there is, I think the next picture will give the picture. Okay. What is we found is actually when there is inflammation, there is lot of nociceptive fibers, and we found that something is happening. The total number of autonomic fibers are missing. That means whenever there is inflammation in the fascia, it kills the autonomic fibers so that the total number of fibers will be lesser when inflammation occurs. See, this is the inflammation. Normally when inflammation, there is lot of nociceptive fibers. There will be more density of the fibers. But the pre-inflammatory status, the nerves are more. Inflammation induced an increase in the nociceptive nerve endings, but it also induces a lower intensity or density of the sympathetic endings. So that what means when there is an inflammation, there is a retrograde growth of autonomic nerve fibers, or more autonomic nerve fibers vanishes from that area. Okay. So we are having, this study is having, let's say this is 2019. We used to say that this is one of the groundbreaking study which says that the neurogenic inhibition or neurogenic inflammation is the main factor producing pathological alteration, peripheral sensitization, and central sensitization. So substance P means it's a stain we use to identify the nociceptive fibers in the fascia. So we took a fascia from the rat. We first stain with the CRGP that stains the sensory fibers. Then we found that the outer and inner layer is having more fibers. Then we injected hypertonic saline. Then we took again another facial part and stained it. Then we found that there is a high percentage of increase in the nociceptive fibers. But along with that one, there is a reduction of the autonomic fibers on the area of inflammation. Okay, I think that is clear. And see, this is our groundbreaking study. As I mentioned, 40% of the fascial, 40% of the sensory nerve, 40% of the nerve supply of the fascia is actually post-ganglionic sympathetic fibers. Post-ganglionic sympathetic fibers, you know, sympathetic and parasympathetic fibers. And these post-ganglionic sympathetic fibers are vasoconstrictors. You can see that always there is arteries moving along with the autonomic nerve fibers, because that is why called these post-ganglionic sympathetic fibers are vasoconstrictors. So as I mentioned earlier, what is the point in this area is, you know, when you are having stress, you will feel more pain. When you are having stress, your post-ganglionic sympathetic fibers will be active. When you are having post-ganglionic sympathetic fiber is active, it will cause us vasoconstriction on that area. When there is a vasoconstriction on that area, it causes temporal ischemia on that area, which stimulates the nerve endings to produce neurogenic factors. It's called a neurogenic inflammation, and pain happens. So that is why those people who are having more stress, or more those people who are having disorders like anxiety disorder and all, having whole body pain because of this mechanism. I think it is clear. And another study we have seen is actually, to be honest, normally if you are touching your back, the sensation of touch, or I am pinching you in the back, the pain, feeling of pain in the back actually goes through the dorsal nerve root of thoracic 13, L1 and L2. Okay, and we have done an injection of nerve growth factors into the rat. One is into the muscles somewhere far from the spinal cord, another is in the fascia, and another is in the muscles. We found that the intensity of inflammation when we are injecting the nerve growth factor or hypertonic saline into the fascia is maximum. See, the inflammation of a single injection produces 33.3% neurogenic inflammation in the fascia, where it is 14.8 only in the muscles, which is almost near to the control. What does it mean? Most of the neurogenic inflammation and pain is coming from the fascia, because fascia contains abundant amount of free nerve endings. And what is I have to mention is, when there is such continuous pain, we have given injection to pain, we found that the pain sensation is not only traveling through thoracic 13, L1 and L2. Since there is lot of pain intensity, it started traveling through L3, L4, L5. That means now the area where it is supplied by sensorily controlled by L3, L4, L5 also feels pain. That's why most of the non-specific back pain is vague in nature, because it started capturing more what is called spinal segments to transfer the pain. And this process is typically called central sensitization. So this peripheral sensitization, what we have done is immediately, this happened within 48 hours. That is most amazing thing, causes the central sensitization. After this central sensitization, what will happen? This will go to the spinal cord, where it will be in the neuro, causes excitotoxicity that will produce more nerve growth factors, glutamate and everything. It will be continuous neurological excitation that will go to the cerebral gray matter and limbic system, and it will work on the structure of microstructure of the brain. Then it will cause us, central pain inhibition. Your pain threshold goes down, and you will feel, wherever you touch, you will feel pain at the end of the day. Otherwise, it is called fibromyalgia, chronic pain syndrome, chronic fatigue syndrome. Life goes in that way. So it's very complex, very complicated things. I'm just telling in a very simple, as much simple as possible to make it easy to understand for you. Okay. Maybe this, I'll be telling some stories, but it is not necessary that you have to understand all the stories. It's simple. Chronic pain is really complicated. That's what I want to say about this one. So a recent study actually says that in comparison with the healthy controls, patients with the chronic myofascial pain exhibited microstructural abnormalities in the cerebral gray matter. And these lesions were mainly distributed in the limbic system and the brain areas involved in the pain matrix, which are right anterior cingulate cortex and medial prefrontal cortex, like we used to call it as the typical classical central sensitization. The degree of gray matter reduction is compatible with the natural decline occurring over 10 to 20 years under normal conditions. So when the pain is there, actually you are getting older faster, right? Your brain started degenerating. So that is something beyond our logical understanding, how the life goes. And what happens when there is a pain? The impulses travels through any pain travels through the dorsal horn through the dorsal horn neurons and reaches the spinal cord. Then it causes an release of extracellular calcium and nitric oxide, which stimulates the nerve endings to produce substance P, glutamate, all the neurogenic factors, which causes neurogenic inflammation. That will go and finally pain giving an impression that always there is a pain. So brain will feel pain even without there is a sensory stimuli, or brain will feel pain even with a sensory stimuli. Okay, so when there is central sensitization, even normal touch, you will feel as nociceptive, because already your nervous system is over responding or over exciting. So this is actually typically what is happening in one way, the fibromyalgia, although we don't exactly know what the exact mechanism of fibromyalgia is. Okay, so all these are actually, I'm just explaining about the neurogenic factors, which is not that much important for you at this point. So I'm just skipping all this information for a while. And the next one also saying the same thing. You know what, I think you might be knowing about chronic pain, spatial summation, temporal summation. So temporal summation is, for example, if you are touching on area repeatedly on a fibromyalgic patient, the patient will feel severe pain after the repeated stimuli. So that means the stimuli are accumulating and giving a strong pain. Next day, patient will say that I cannot even move my hand. So if you are giving some sort of manual therapy to a fibromyalgic patient, it will cause a temporal summation. Next day, the patient will say that I cannot even lift the hand because it was so painful. And another one is, the spatial summation. If you are touching different parts of nearby areas of the body, all this area will be painful. That's called spatial summation. So actually now we are using different type of treatment that uses the unlearning process, because this is a learned behavior. We learned because there is some neuroexcitotoxicity which produces the brain to change his neurotransmitters, and which ultimately causes behavioral changes. And because of the behavioral changes, now you feel everything as a pain. So we have to unlearn. Even the medication what we are using is actually to facilitate the brain for unlearning. And the role of glia is actually a big area of debate or discussion nowadays on the fibromyalgia pain. Okay. Now the time is, yeah, we are good in time. When we are telling about the back pain, okay, because of the repetitive strain injuries, because of the continuous sitting, because of the stress, because of your faulty postures and all, there will be micro injuries, and that micro injuries will causes inflammation in the lumbosacral fascia, and which is actually causes altered movement patterns, and which causes sensitization of the nociceptors, peripheral sensitization followed by central sensitization, so that even the small normal touch sensation, you will perceive it as a pain in the later stages. Also, we can call it as dysfunctional proprioceptive signaling. So life goes like that. So I'm just unwinding what we have learned. Fascia is highly innervated, 43% of the sensory, 40% vasomotor, 17% motor. Among the sensory, mainly it is, let me enlarge it. So among the sensories, only 5% is Ruffinier Pacini, 20% muscle, so this is a myelinated. So 20% is myelinated, 80% is the free nerve endings. So fascia contains mainly free nerve endings, and only 20% is the myelinated. The myelinated is actually nothing but the muscle spindles. And we are now less thinking about the Golgi, Ruffini, and Pacini. The most amazing finding we have found this year, from 2019, is actually fascia contains a lot of autonomic fibers, which is vasosympathetic and vasoconstrictor. So there is a high role. Fascia is directly related to stress and pain producing in our body. And we know that we as a physiotherapist always mobilizes the fascia, mobilizes the capsule. When somebody is having a frozen shoulder, we are having anterior glide, we are having posterior glide, because it is learned that the capsule is richly innervated, a lot of sensory fibers, and actually the capsule stiffness causes everything. But if you are a musculoskeletal physiotherapist, you will be noticing always one thing. Most of the frozen shoulder patients are complaining pain either here or here. They never complains the pain that they're having pain here. So either they have complain pain here, most of them complains pain here, and some of them will be complaining pain there. Okay, I think you might have noticed this one. So we have conducted a study that was actually a really nice study. It was done on human beings. Those patients who are actually done the total hip replacement surgery, we took some cells, some fascia, some pieces of tissues, including all. For example, let's say that we have taken pieces of subcutaneous tissue, superficial adipose tissue, superficial fascia, deep adipose tissue, deep fascia, muscles, tendon, ligament of capsule, round ligament, and everything. And he put under microscope after staining. We saw the skin. It is abundantly innervated, lot of nerve endings and capsules there. Of course, we know this one. Subcutaneous tissue. So you can see there is nerves, there is free nerve endings, and there is encapsulated nerve endings, and there is motor nerves also. Actually, maybe that is a traveling. This is maybe Ruffini Pacini cross-cutting area, because Ruffini Pacinis are actually a bit bigger. Superficial adipose tissue, fat is there, but you can see dots there. That means there are nerves even in the superficial adipose tissue. Superficial fascia, see, it's almost like the same, like not exactly, but almost same like the skin. Lot of dots. That means superficial fascia is highly innervated. Deep adipose tissue, let's see that. Yeah, there are few dots here. So it is somewhat innervated. D fascia, again, you can see a lot of dots here, mosaic-like. That means it is also innervated. Muscles. Muscle is also innervated, but you can see a lot of area which is flat and faint. And these are the motor neurons, okay? Or the motor nerves, which is for the muscles. And tendon. See, tendon is like whitewashed. And there is less neurons. And that is why we used to always say that the tendon is actually devoid of blood supply and nerve supply. Okay, the surrounding area is giving all these things to the nerve tendon. So tendon is like a symbiosis. It takes help from others to survive. And after D fascia, what we are having is, let me see, what is this? After D fascia, we are having the capsule, ligaments, and round ligament. See the capsule. We learned that capsule is highly innervated. This is the capsule. See, is it highly innervated? It is very less density of nerves only in the capsule. Okay, so when we have analyzed the density of the soft tissue innervations, we found that we knew that skin was the best or maximum number of nerve innervation was in the skin, because skin is getting the information for us. After that, the superficial fascia is the second most innervated. This was a new finding actually. Superficial fascia is the second most innervated organ in our body, followed by ligament of the capsule. Actually, ligament of the capsule is an expansion of the D fascia, followed by the D fascia, superficial adipose tissue, subcutaneous tissue also there, ligament, and the least one, the muscle. Where is the muscle? See, muscle is here in like a sixth position or something like that. The least, innervated part in our body near the hip joint was capsule and tendon. So this was amazing finding for us. So what was the theory? We found that even you are removing the capsule, the patient won't have that much pain because the innervation of the capsule is very limited. So I don't know how much this will be applicable in the further surgical reviews and all, but this is the anatomical review they have done recently. As I want to say, fascial science, fascia is a new field we are studying, but doesn't mean that whatever we are telling has to be the same in the next year also. So warning, science is in progress, be careful, but no, so far, whatever we have found as a new things are logical. We could able to connect the stories. We could able to fill the gaps of an area where we were not knowing what exactly happening. Okay. Actually, maybe I know that your brain is getting more full and full because of a lot of bombarding information. This one is simply, I'm telling about D fascia, okay? As I mentioned in the beginning time, I told D fascia can be either aponeurotic fascia or epimysial fascia. An example for aponeurotic fascia is thoracolumbar fascia. An example for the gluteal fascia, epimysial fascia is gluteal fascia. Aponeurotic fascia, the function is, as I mentioned, finding out how much it is moving, proprioception. Okay, see how much thick is the density of the rhomboid structures. It's like a spider web, right? So anything, if you are stretching this one, like you are moving forward or rotating, this fascia, when it finishes the rotation, will causes the stretch of the rhomboid structure of the nerve fibers. That will give you the information that, okay, my body is turning, my body is stretching, my body is bending, like that. Similarly, if you are seeing the epimysial or gluteal fascia, even though there is rhomboid structure, it is less dense because, gluteal fascia function is mainly to detect anything going wrong or muscle coordination or nociception. So doesn't need that much of nerve endings like that. So any aponeurotic fascia will be richly innervated. Any epimysial fascia will be less innervated, and aponeurotic fascia function is proprioception. Epimysial fascia function is coordination of movement and nociception. A lot of studies. See what the picture is showing is actually when you are stretching, when you are stretching this web like aponeurotic fascia is actually stretching the rhomboid structure, producing the feeling of you are getting a tension. So that tension is proprioception. So we are getting a lot of proprioceptive inputs from the fascia. So as I mentioned in the beginning, everything in the body is interconnected. And this beautiful picture, amazing photo, I used to say, from the STECO study in 2020, showing how all the fascia is continuous. Here, the carpal tunnel, this is the carpal tunnel area. Carpal tunnel, you can see the epimysium is continuing as the paraneural sheath over the median nerve. That is why there are a lot of studies, if you are searching on the facial manipulation of the shoulder, facial manipulation of the back actually reduces the carpal tunnel syndrome. Because actually, since it is a continuous structure, you can actually decompress that area even without releasing the carpal tunnel area, mobilizing the carpal tunnel area. So everything is continuous. Even nerves, muscles, epineurium, perineurium, everything is interconnected. One area of dysfunction because of what I mentioned, muscular pathologies or muscle spindle hyperactivities and all will cause us, or neurogenic inflammation will cause us that area, and eventually the whole body will be affected. Okay, somebody who is always keeping the mobile like this and reading and walking may be having overexcited neurogenic inflammation on the upper cervical extensor areas, eventually will cause back pain and hamstring tightness and calf tightness, plantar fasciitis, later may develop into even fibromyalgia or body symptoms, tiredness and fatigue, and it goes like that. As years goes without, we are not changing our behavior or habits. When I was studying my BPTs and all that time, like kinesiotape, I think MPT time also, kinesiotaping was considered so magical. People started attending kinesiotape courses here and there because saying that applying kinesiotapes, it's like a fancy things. In the sports area, people will be having multiple colored bands attached over the body and running. So we believe that, okay, this is magical. Now we found that actually even the kinesiotaping mechanism is nothing but fascial. Okay. Wilke in 2020 has conducted another study. They placed the person in the prone position, and actually they have wind him, restricted him in this position so that he is not moving. They put on high quality ultrasound on the popliteal fossa, just into the higher level to see the hamstring muscles here. Then they actually done passively dorsiflexed the angle. When they passively dorsiflex the angle, they found, actually the ultrasound founds the changes in the superficial fascia also. So what they've done, when they mobilized, when they passively dorsiflexed, not only the hamstring muscle, the superficial fascia here also started moving because of the reticularis cutis superficialis and reticularum, fascia reticularis, retinaculum, deep things. These are the connections. This is the connection between the skin and the superficial fascia. This is the superficial and deep fascia. When the muscle is moving like this forward, automatically the retinaculum cutis pulls the fascia also along with that one. And it was calculated as 13% of the muscular movement happened here is transmitted to the superficial fascia. You can think in the reverse direction. If you are putting kinesiotape, that will be transferred the same amount into the muscle, though minimal, right? So when you are putting a kinesiotape, actually, you are working on the fascia in reality. Okay. And DOMS, whenever you do exercise after 24 to 72 hours, you will be getting muscle pain. Now it is delayed onset muscle soreness is a misnomer. It should be delayed or onset facial soreness, because studies are saying that fascia rather than muscle tissue is important in DOMS associated sensitization. And the fascia would become more sensitive than muscle when DOMS is introduced. So DOMS is a misnomer. Maybe in the future it will change. We need more evidences to prove that it is really DOFs, not DOMS. Okay. Now we are actually reaching to the end part of today's presentation. Fascia's role in pain. How the fascia is actually helping in or controlling or moving in pain. Okay. Fascia could cause pain due to we can classify this reason mainly. Number one is altered myofascial force transmission. I had a facial stiffness here because I am not using my hand overhead, always using my hand for typing computers, so that I developed localized joint stiffness here. It can cause altered myofascial force transmission and gradually facial dysfunction. And pain, of course, dysfunction, it will be pain because fascia is having a lot of nerve endings. Level 2 means sliding changes and structural imbalance. For example, you are having postural problem, prolonged postural problem, having a kyphosis. Your body structure will start changing. Some area it will be elongated. The fascia and muscles will be elongated. Some area will be contracted. The fascia will be contracted. Muscle will be contracted. There will be less space for the muscles to contract. A lot of trigger points. And pain, fascial dysfunction. Level 3 is the pathological alteration. When there is an injury, when there is an repetitive strain, inflammation occurs. As I mentioned, initially it will be causes local neurogenic inflammation, release of glutamates and other inflammatory areas, which causes desensitization sensitization of the dorsal horn of the spinal cord, which in turn causes desensitization or deconditioning in the brain, including the limbic system, and that causes a cascade of events causing reduced endorphin, enkephalins, and opioid mechanisms and chronic pain. So we can call it as level 3 pathological alteration can be peripheral sensitization at the beginning phase, and if it is not intervened or halted or stopped at that phase, it will go to central sensitization. This is what I meant. Level 1, altered myofascial force transmission. So this person is sitting like this, or I am just not using my hand overhead so that there is stiffness. The aponeurotic fascia, like the gluteal fascia or the fascia of my deltoid muscle, could perceive motor directions, becoming the peripheral map of proprioception. So that it is not getting the sufficient flexibility, so that it causes, like anything which is you are moving more, causes more pain, and there will be more stretching of the rhomboidus type of nerve fibers, which will produce pain. This is mainly with the postural problems for those people who works in an area where the continuous activity comes. At this point, I want to connect you to myofascia connectivity and myofascial force transmission. You may be already knowing that the MS has classified our body into different connectivities, like a superficial back line, spiral line, superficial front line, then the deep functional line, back deep functional line, front upper extremity lines, like that. So this is, for example, superficial back line. You can see the whole muscles are embedded in the fascia. That is why when I'm telling that when there is an injury or inflammation on the plantar fascia, it can cause a dysfunction of the calf, it can cause dysfunction in the hamstring, it can cause dysfunction in the lower back, in the thoracic area, in the neck, even headache. Okay, so in the next 2 sections, when we are coming tomorrow, you will be amazed by the studies, which is actually demystifying the connectivity of the fascia and how it can be used in the therapeutic conditions. And the most amazing thing is that 30% of the muscle, when the muscle is contracts, the muscle force has to be transmitted. 70% of the muscle force will be transmitted from muscle to tendon, or muscle to bone, or muscle to muscle. But 30% will be transmitted to the adjacent muscle, up above or below, through the fascia. So that we used to call it as epimysial myofascial force transmission or myofascial force transmission. So myofascia not only controls the flexibility and extensibility, it also helps in the force transmission, and it is estimated that 30% of the force transmission actually occurs through the fascia. Okay, so it is actually, we used to call it as epimuscular myofascial force transmission. And the myofascial meridians are the lines or connectivity, which according to Mayes is the one which actually controls which says that the fascia is a continuous structure. If you're having a back pain, you will eventually develop neck pain, you will eventually develop hamstring tightness, then calf pain, plantar fasciitis, and like that, because of this facial connectivity. So myofascial meridians is actually a simplified version of the facial connectivity. You might have missed one thing while you are observing your patients and all, while they are doing the activities and all. Most of the activities are diagonally controlled. Have you noticed that one? Most of the activities where you need to pain to be generated. Sorry, most of the activities where you need force to be generated, it will go for a diagonal type of pattern. See here, this is a it's a diagonal pattern. See here, it's a diagonal pattern. See here, the force is producing the other extremity. Look the position of the other hand, how it is then. It's a diagonal pattern. It is diagonal pattern. So diagonal patterns or spiral patterns are having a lot of importance in our life. This is one of the newest things regarding the fascia is concerned. We already know that a superficial back line, the relationship with the hamstring and rectus spinae, the relation with the calf to plantar fascia, everything we know that. But this is actually, we seriously missed this connectivity, the diagonal or the spiral connectivity, which we use to produce massive amount of force. For example, see the three pictures. She is walking. Her opposite leg, she lifts the leg and opposite hand. It's in the diagonal pattern, but it's relaxed. When she's jogging, again, when the leg moves forward, the hand is also just moving, but not in a bigger way. When she's sprinting, what is happening is actually, let's say this leg, when this leg needs a lot of power, actually, the opposite latissimus dorsi is contracting in such a way that it's like a passive pull of that leg taking it. So not only the muscular force she is using, but also the spiral connectivity with the passive tension or fascial tone also she'll be using. See, the position of the hand changes according to the mode of running. And it is found that in the EMG activity, we found that when somebody is walking, there is increased EMG activity of the latissimus dorsi. Okay, so we use this diagonal relationship of the fascia to produce extra or powerful force when we need such powerful activities. And this is actually some of our Wilkes famous studies, which is substantiating altered myofascial force transmission. The first study in 2016, what they have done is actually, they have done hamstring stretching and calf stretching, and they found that it causes increase in the cervical range of movement. Then, after getting that information, they done another study in 2017, where it has two groups. One group contains the same like hamstring stretching and calf stretching, and the second group has directly done the cervical stretching, and they found that there is no significant change between the cervical range of movement obtained between these two groups. That means if you want to get cervical range of movement, you just need to stretch any of the part of the superficial back line maybe, and that will increase the cervical range of movement. Suppose you are having a burn patient and the patient is having neck stiffness. You cannot touch that area. Work on the calf, work on the plantar fascia, work on the hamstring, or work on the lumbar spine, okay, or lumbar rectus spine. That is what they told. And another study in 2018, which was published in 2019, they collected around 150 people, students, and they asked them to do 120 seconds of rolling a ball under the plantar fascia or under the sole. And they have done a pre and post sit and reach test. And they found that even 120 seconds of release of the plantar fascia increases the sit and reach test length in a statistically significant level. That means a small amount of force change, alteration in the force of the facial connectivity is making generalized changes. You can attribute this to the facial connectivity and the myofascial force transmission, but as a deep fan of myofascia, I used to contribute this to the autonomic or the sympathetic connection the fascia is having. When you are releasing, there will be immediately sympathetic contraction, followed by parasympathetic relaxation. That is normal sympathetic parasympathetic mechanism. That time the fascia goes for relaxation, and you are getting these things. Of course, myofascial force transmission may be a reason, but it's a culmination. We cannot only say that it's all happens because of the myofascial force transmission, right? And this is an amazing study done by in Italy, and I was actually part of the review of this study. They had 5 cases of the persons, all with the non-specific back pain. Okay, and they have done facial manipulation on this person. So the criteria is they have to do facial manipulation 20 centimeters away from the area of pain. So this is the area of pain, of course, non-specific back pain. So they have done 4 sessions of facial manipulation on the calf. In second case, they have done on the adductors and the anterior and lateral side of the calf. Third cases, they have done the same thing, but it's more on the anterolateral sides or anteromiddle side of the calf. And fourth, they have done on the upper and lower extremities. And amazingly, after the third and fourth session, the pain started reducing substantially. Even though after 1 or 2 months, it came back, but they didn't treat any of this patient received treatment on their back. It is far, far away from the area of pain, and there is a statistically significant reduction of the pain. Okay, so what I used to say here during my students and presentations, like we shouldn't analyze the elephant with blinded eyes. This is the ideal time. We have to start our looking the eyes, and we have to open the eyes, and we have to see the elephant in our room in a more precise way. Let's put more lights to see the elephant clearly, but the musculoskeletal mysteries are still an elephant in the room, and we are blinded. But we can open the eyes one by one to see what exactly it's happening. So we can attribute this to the sliding and structural imbalance, where the facial connectivity, facial stiffness, and the facial innervation plays a huge role in aligning, managing the facial stiffness, pain, and functional gain or extensibility, flexibility, many things. This was the same study. This patient is having sacroiliac joint. This study was published in 2020, actually. They have find out the patient who is having sacroiliac dysfunction. They have done pressure algometry and recorded the pain. After that, they have released the calf muscle here for 15 patients and assessed the algometry changes and find that there is a statistically significant reduction of the sacroiliac joint pain when they treated areas far away from the sacroiliac joint. Okay, so all these are actually giving us the connectivity and explanation based on the what we said is the facial connectivity, myofascial meridians, and for me it is more into the neuronal aspects of the facial and myofascial system. So I used to call this system where the bone, muscles, and fascia all together as osteomyofascial. So the combination of the 3 different words to make it more clear and understanding. Okay, so when we are telling that all these type of activities are causing because of the facial meridians, somebody was asking, so like if we are doing foam rolling on the left leg, actually your pain in the right leg also reduces. That you cannot say because of the myofascial meridians. So it is a generalized holistic effect when you are putting something because the fascia has generalized innervation and autonomic representation, to be honest. Okay, and latest study, very latest study found that when mechanical stimulation of humal dermal fibroblast regulates pro-inflammatory cytokines. When there is an injury, when you are attending sports, when there is an injury, the cells will produce IL-6, interleukin 6, which is a inflammatory one, okay, which causes inflammation. And if, for example, you are participating in a sports activity, after that you are doing a prolonged facial or muscular stretch or foam rolling, it will actually, a cyclical strain results in lower interleukin 6 and interleukin levels, such so that we can say that the fascial mobilization is having a pro-inflammatory or anti-inflammatory effects, whereas the interleukin 6 and other such neuromodulators are concerned. The same thing is applicable for the scar and the post-trauma cases, where in the facial dysfunction actually causes a lot of issues and the sliding will be totally affected. The third form is actually the central and peripheral sensitization. you will be ending up with the life with the fascia loses hydration, it loses sliding, it become more stiff. There will be sprouting of nociceptors, and there is loss of sympathetic fibers, so that it loses its balance, and there is more peripheral sensitization leading to central sensitization. Then the brain changes, then hormonal changes, multi-system, and the life when it reaches to the central sensitization goes in a different way. It will be having effects on many structures like your digestion, irritable bowel syndrome, your urinary system, your muscular system, vision, energy level, joint pain. Even if it is female, menstrual cycle changes, a lot of things will happen along with that when you are into the central sensitization phase. Okay. And when it is a central sensitized, it requires longer time to to get into picture. Okay. And this is the last slide I will be saying today. And then we will continue tomorrow with the further things. I like these studies, like they have taken 4 groups of porcines or pigs, a control group, a hobble group. This is hobble, like a immobilizer, and an injury group, and a hobble and injury group. What they did actually, one control group, they didn't do anything. They let them to walk as free. The hobble group, they immobilized them so that they cannot walk. Okay, there will be movement is restricted. The third group, they produce an injury near to the thoracolumbar area on the lower back. And the fourth group, they produce an injury and they restricted the movement. And when they analyzed, they found that 52% of reduction of the flexibility of the thoracolumbar spine. The thoracolumbar spine couldn't be able to stretch more than 48%. 52% of the elasticity or stretchability of the thoracolumbar fascia has lost when they conducted with an ultrasound elastography. And it was 28% in the movement restriction cases. Movement restriction injury almost same, see. So that means when you are restricted your movement as you are in an office not moving, or you are immobilized because of the plaster and all, you are having an injury, your life will be more pathetic. Your thoracolumbar fascia or any fascia, which amponeurotic fascia, will go for very restricted thing. So example for injury movement restriction means this person every day sitting like this. Okay, so this movement is restricted, and because of this position, repetitive strain injury causes injury. So replicating this phase of injury position. So we are making ourselves injurious, our life patterns making ourselves injurious, so that like it affects our entire system. Even we are losing our brain, like as I mentioned, our brain is aging when we are under stress and pain. Okay, and tomorrow this is the points I'll be concluding for today. Fascia can be pain generator, or they can simply perceive an alteration of tension originated far away from the site of pain. As I mentioned, restriction in the calf or calf pain can cause neck pain. Probably the effectiveness of fascial treatment and the number of sessions may vary according to these possibilities. If it is only a structural alteration, 1 session, 2 sessions is enough. If it is central sensitization, it may need months. In chronic pain, there may be an increased nociceptor inputs and reduced sympathetic representation with increased dorsal horn activity leading to peripheral and subsequent central sensitization, means increased sensitivity to nociceptive inputs. Okay, so this is the comprehended or abstract form what I have presented today. Tomorrow I'll be moving. Still are you addicted to the muscle injury and muscle pain words? This is actually, I put it as a question mark when we know that things are not into according to that one. So tomorrow we'll be understanding about how to develop a clinical application framework and how to see a patient with the different structural changes, and how to induce the exercise parts, how we have to design our exercise, how the different type of exercise will work, and what are the different way of approaching the facial dysfunction. This will be tomorrow, and I'll be explaining something about the facial connectivity also tomorrow. I hope that you had some sort of idea. Normally, I believe that a good presentation, if it is very thick, maybe 10% to 15% will be the understanding. But if you are able to read after a presentation, you're able to retrieve the studies after attending a presentation, I think the knowledge you will be acquiring will be very, very, very huge. So at this point, I am just stop sharing, and any doubts, of course, we will be in the halfway. So maybe the doubts will be incomplete, but any doubts you can ask now. And tomorrow I'll try to finish it a bit earlier so that there'll be more area time for us to do for the Q&A session. So I'm stop sharing.
Yes, sir. Yes, sir. Thank you. There are questions in the YouTube, sir. I'm just reading here from Professor Arunachalam. Will you categorize fascia as a passive structure or active one?
It's the same. I think the fifth slide what I was telling. It was considered as passive at the beginning. Now it is not at all passive. It is dynamic because of the presence of. See, if then there is, the nerve structures are so much inside, and it is going to control your system. And the fascial tone that is centrally controlled. We have to say that it's a dynamic structure. Anything in our body which is having a role in the pain, actually it's dynamic. So we started understanding our concept of fascia as a passive when we started explaining the mechanism of fascial pain as piezoelectricity and all sort of things. It was passive. Now it is, we can say that it is more dynamic explanation, and fascia is dynamic as far as function and pain is concerned.
Yes, sir. I request participants to join Zoom meeting. I have posted the password and link code in Facebook, and also shared the link in our WhatsApp groups. Those who are
sorry, there was a question that participants are asking you to go a little slow. I now only saw the next section. I'll consider.
Yes, sir. Yes, sir. No, by the time your pace was slow, so that's why I didn't interrupt.
Okay. Maybe initially. Okay.
Yes. At first, it was so fast.
Yeah.
And from Kollal Kishore, sir, can you explain central sensitization again?
Okay. When you are having a pain in a local area, we can call it as a local inflammation. Let's say that practically, I am going to inject hypertonic saline in this area. Then my nerve endings from that area started releasing glutamates and all sort of things, as because of the nitric oxide and calcium, all sort of things in the muscles and everything there. So this causes increased neurological inflammatory areas on that area, which causes sprouting of the nociceptors within 48 hours. So this neurogenic inflammation on this area causes the first level of the signs of sensitization, where there will be a lot of more number of nociceptors. So whenever there is an inflammatory mediators and neurogenic inflammation starts, that will cause us increase in nociceptor inputs. When the nociceptive fibers started increase, as you can think about the picture, the number after the inflammation, the nociceptive fiber density was so high, but the autonomic nerve fibers started dying, because that is actually a protective mechanism, we can say. That is why it is vasoconstrictive. So that is very complicated. I can explain maybe tomorrow, but this is it. Once it is there, neurogenic inflammation started, lot of nociceptors are there. There will be increased sensory inputs to the dorsal horn neurons. That increases sensory inputs to the dorsal horn neurons will cause us sensitization of the nerve endings of the dorsal horn neurons, where it causes increase in the glutamates and the substance P amount and all, which causes excitotoxicity of the nerve endings, means there will be more production of the neurological mediators, inflammatory mediators in that area, producing, releasing, so that even the touch I'll be feeling as pain sensation, because my nerve is now hyperexcitable. My dorsal horn is hyperexcitable. So this will go to the brain, where there is limbic system, thalamic system, and the ACC and the gray matter, microstructural gray matter. There is a huge change happens because of the the neurotransmitter modulations that causes the reduction of the pain tolerance. We see those who are military people, those who are working in the war field, they are so keeping their body and muscle and body so trained and all. their brain is optimum and their system is optimum, even when they remove their leg or hand during that time, it's called battlefield analgesia. They cannot feel it, the pain. But even a normal person who is less mobile and he's having a lot of inflammatory mediated in his body, his brain's pain tolerance will be very less. I think I'll go back to that picture for a short time. Advanced share.
Yes, sir.
Yeah, that will be easy for. I think we have covered a lot of slides in between.
Yes, sir. Yes, sir.
Okay, so if I'm coming to that picture, okay, this is the picture I want to explain. Okay, see, this is the neuroexcitotoxicity at the spinal cord level. And when it happens, there is a lot of gray matter changes, microstructural CBF. There are a lot of studies with the cerebral blood flow find that those having chronic pain, even the CBF, cerebral blood flow, is affected. All things in a general reduces the pain threshold, so that finally a pain signal is sent to the brain from the dorsal horn. Even the sensory input is tactile. So it is overstimulation of the dorsal horn, excitotoxicity and hyperexcitation of the neuroterminals, which is in the tertiary centers like the spinal cord and thalamus, which causes a confused system where what is happening is the neuromodulators. There is neuromodulators, means glutamate, substance P, and the nerve growth factors increase release in the brain, causes reduction in the pain inhibitory factors like endorphin, enkephalins, and all. At the end of the day, the brain will understand even your touch as a painful or nociceptive stimuli. I think explaining chronic pain is always difficult, but I think this is the simplest way to say the truth. There are a lot of numbers. I don't know what is the number means. Hello.
Oh, they are for attendance purpose, sir.
Okay,
I
okay.
them to post and
Any other doubts? They are noted.
yes, sir. There are some questions, sir, from Vasilis Karpousis.
I was.
Yes.
Okay.
I think one of your friend.
Yeah. Actually, is my friend. He is working here. He's basically British. He's from Greece, actually. That is why.
Yes, sir. Greece. Yes, sir.
Yes, Thank
you, Vas, because ExRxIndia reached Greece because of you. And yes, does cupping have the same effect on fascia as kinesiotape?
Yes, that's a good question. Actually, nowadays, our new, like I'm a part of the Fascia Research Congress Central Committee. It's like a student wing. What they are going now is thinking that since all this kinesiotaping, cupping, all sort of activities are producing facial effects, nowadays they are going to nominate a terminology of all these things under myofascial decompression therapy. So here onwards, maybe from 2021, actually the next fascia conference has to be this year, but postponed because of the COVID. It will be in the Vancouver next year in the Canada. They will be defining this one. All this activities like kinesiotaping, capping, even needling, everything will be under myofascial decompression therapy. So as it says, yes, cupping is having the same effect what exactly the other complementary therapies working on the minute levels of the fascia. And when it is about acupuncture, most of the sham points are actually in the area, or the acupuncture points are the area where the nerves, blood vessels and everything comes out. So any needling on that area actually immediately depolarizes and the facial relaxation and incoordination changes. I'll just give again share my slide for showing something amazing things along with the question, the answer to was. Okay, so I had to go back a lot. So tomorrow we'll be explaining about the treatments, but I'll be having something to show regarding the acupuncture. Yeah, sorry to move all these things in this way so that we are losing our surprises for tomorrow. Anyway, okay, let me come to that one. I have an acupuncture picture here somewhere. Okay. Where is my acupuncture picture? My God, I couldn't find the acupuncture picture. Let me see one more time. Yeah, I think I will get it here. Okay, so here we go. We are having an amazing picture of see acupuncture meridians and fascia. See, the superficial fascia is perforated at specific points at a triad of nerve, left vein, large body in the middle, and the artery. Most of the perforating nerves in these triads are unmyelinated sympathetic nerves. According to German anatomy professor Hamad, most of these perforation points are topographically identical with the traditional Chinese acupuncture points. So what does it mean that even acupuncture, dry needling, everything will be categorized under myofascial decompression therapy in the future as the science and evidence are moving in that direction. I think that's actually gives us some information for was doubt.
So can we move on to the next question?
Yes, please.
Sir, does infrared advised on fascia pain?
Actually, when I'm telling about fascia, since it is fascia's main part is epimysial, that means the fascia which is embedded with the muscles. As I mentioned, when there is a misunderstanding between the fascia, epimysial fascia and the muscle spindles which is trapped in between actually got all the affections. And having said that, like the misunderstanding between the fascia and the muscle is very high when the muscles get stuck, and when it is muscle spindle is overstretched or continuous stretch, muscle will stay in a state of contraction, like tetanic contraction. So when you are having something like a hot pack before or after facial mobilization, you used to get some type of effect. More than that, infrared or whatever other modalities is giving the same type of system where you are giving a relaxation. From the point of fascia, 40% of the fascia nerve endings are autonomic. You have to consider that when you are exposed to cold, there will be sympathetic activation and there will be vasoconstriction. Okay, so what will happen? You will feel more pain because there is high chance of neurogenic inflammation because of the stiffness and muscle fascia incoordination. That is why many people used to say that when the cold time, they are having more facial restriction and stiffness they feel. Actually, this is because of the autonomic function. So wearing inner or keeping your body warmer or using any devices that keeps your body warmer actually works on the fascia and keeps the fascia a bit relaxed because of the autonomic innervation of the fascia.
Yes, sir. The next question is from Srishti Daura. Can we say that the SI joint pain is actually a facial pain?
When we are doing research and we are studying, what we do is actually, we are considering sacroiliac joint pain as a pain. We are not going to analyze what sort of sacroiliac dysfunction is there. So when I'm telling in that way, when our approach into the peripheral area, which is the sacroiliac joint is actually connected to the superficial back line, superficial front line, whatever it is, when then approach is reducing the pain, we have to say that many of the components of the sacroiliac pain is fascial. So, I never support any of my team to say that every pain in the world is fascial pain. No, it's a combination of the pain. Sacroiliac joint dysfunction can be there. For example, if your muscles and fascia is stiff and incoordinated, not properly working, your joints also will be in trouble. Your biomechanical alteration will be there. And that can cause pain, secondary pain. So any type of pain combination will be there. So it's like untying somewhere makes things coming back so that, our body can start working on correcting the system. So sacroiliac, when you walk itself, lot of changes happens on the sacroiliac joint. If somebody is pulling from some direction because of the facial restriction and you are able to reduce that facial restriction, the body itself can correct back. So that can be an explanation we can give rather than saying that sacroiliac joint pain is a facial pain. A component of facial pain can be there in the sacral joint. but it's most of the time secondary, as I mentioned, because of the pulling or alteration of the muscle force causing sacral joint to not to function properly. When we removed that one, the joint started aligning itself. Okay.
Yes, sir. Can we move on to the next question, sir?
Yes.
Muskan Agarwal is asking, what is Pacini and Raffini?
So we are having, encapsulated nerve endings, there is called Messinis, corpuscles, Ruffini, and Pacini. And these are encapsulated nerve endings, which are big in size. These are mainly for pain and pressure threshold, which measures things. So earlier in our concept, like 2008 and all, we were presenting more on that the fascia contains a lot of Ruffini and Pacini, thoracolumbar fascia contains a lot of Ruffini and Pacini, so that is why they are functioning as a proprioceptors. But the truth is, in the thoracolumbar fascia, so far nobody has found any Ruffini and Pacini corpuscles. These are sensory endings. So that is why we found that these are rhomboid-shaped nerve endings actually making the difference. Okay.
The next question is from Swapnil Kulkarni. Can you please again explain stress and back pain relation?
Our fascia, 40%, 43% is sensory fibers, 40% is autonomic fibers. Autonomic fibers are post-ganglionic sympathetic fibers, which are vasoconstrictors. When you are under stress, your sympathetic system will be activated. Since 40% of the fascia is having or post-ganglionic sympathetic fibers, stress causes activation of the sympathetic fibers. Sympathetic fibers causes vasoconstriction because these are vasoconstrictors. When vasoconstriction is there, it causes temporal ischemia on that area. That stimulates the nerves because of the neurogenic inflammation. Whenever there is ischemia, immediately nerve endings, the beaded structures will start producing release of structures, neurological structures there, neuromodulators like glutamatase and all, which causes pain. So stress and stimulation of the post-ganglionic sympathetic fibers causing vasoconstriction, temporary ischemia, neurogenic inflammation, or stimulation of the nociceptors, or pain perception because of the incoordination causing pain.
Yes, sir. The next question is from Fausia Mustafa. Fascia. How does fascia reduces friction, and how does trigger point forms?
Okay, so this is my son's book actually. So fascia, if we are telling about aponeurotic fascia, deep fascia, it's like different layers of thick fascia. As I mentioned, trabeculae. Do you remember I was telling about trabeculae? Different fascia with the different arrangements of the connective tissue. One is connective tissue is aligned here. Another page connective tissue is aligned here. Next page it is connected here. So fascia is like different layers interposed by or separated by loose areolar connective tissue. And this area, there is a lot of hyaluronic acid and water is there. So fascia moves like this over one another. The thick fascia moves, slides over one another like this. Okay, because of the loose areolar connective tissue and a lot of water and hyaluronic acid. So if there is less water or hyaluronic acid is getting segregated, this movement won't happen, so that it causes dysfunction, so that the muscle spindle will be get trapped here, GT will be trapped here, which causes hyperactivation of the muscle spindle, and that eventually produces over contraction or tetanic contraction of the muscles, produces inflammation, incoordination, muscle imbalance, joint issues, pain. A cascade of events will be created one by one. I think that's clear with my book, right?
So the next question is from Bino Ashish. Can fascia regenerate?
Why you want the fascia to be regenerated? Yeah, since it is contained cells, fibroblast, it can regenerate. Fascia is simply same like other structure. Apart from the non-living structures like connective tissues, since it contains fibroblasts, fasciacytes and everything, fascia can regenerate. Fibroblasts will produce, even there is injury. See, the best way to keep yourself young is keep on rubbing your face. When you keep on rubbing your face, you are stimulating the fibroblast to produce more collagen. As you are aging, you will lose your collagen and other elastins and all. So it will, by fibroblasts will produce more collagen and elastin and all other glycosaminoglycans. So your skin will be very toned. That is why, like people doing all sort of things on the face. It's also facial. Okay. So fascia can regenerate, fascia can modify, fascia can come back to normal. You can, by activity and by means of facial mobilization procedures, you can rejuvenate the fascia. Yes.
Yes. Then next question is from Shantanu Malik from Bangladesh. Which approach should be first during treatment?
Again. Actually, I was reading something. Again, please.
Sir, from Shantanu Malik.
Okay.
Which approach should be first during treatment then?
Again, which
approach.
Okay, tomorrow we will be discussing about that one, because it's you need a brain change to understand that one. I think tomorrow after session will be the best for explaining this question, because tomorrow we are going to explain about the approaches. Okay.
Yes, sir. And Bino Ashish says in compartment syndrome, doctors usually doing fasciotomy. From your informative talk, I understood how fascia became villain in that condition.
Yeah, exactly.
And yes,
and we have even done many studies with the compartmental pressure and the facial role, and we are having very, very positive findings regarding such cases. And the compartment structure and the scar it's going to produce future can actually really affects the performance of the athletes when they do the compartment surgical releases and all future perspectives.
Yes, and from, I think, Professor Balamurugan, systemic inflammation versus fascia. Can you explain?
Systemic inflammation, I don't know what exactly systemic inflammation means, like in any inflammatory conditions. Actually, there is a latest study in 2021 is actually telling about the scleroderma and the fascia. Still, we are in the hypothetical view. Other than what I explained, the way the fascia, the neurogenic inflammation, and imbalance, and the central and peripheral sensitization, anything related to systemic inflammation of any condition like scleroderma and all, we are having less evidences. But you can read books about articles. There are 2 articles released in 2021, but it is more on a theoretical basis that physiotherapists should intervene in systemic inflammatory conditions, because there the facial mechanism is prevailing. So it is one study by Langerwein, 2021. Another one is by the sleep team. So I can't say the answer clearly because it is evolving, but systemic inflammations and fascia is having a relationship. Maybe within another 2 to 3 years, there'll be more evidences on that area.
So the next question is from Atin Banerjee. If TLF release, then both upper and lower body pain relief happens.
TLF means thoracolumbar fascia, you mean?
Yes.
Okay. Thoracolumbar fascia is very sensitive part because it's a fascia and a lot of connective tissue distributions are, depositions are, because when you're walking, actually the thoracolumbar fascia is the one which controls you when you walk. So it is like a passive tension of the thoracolumbar fascia is very important. So it is highly invested by the connective tissues. If you are palpating your side, you can see many bands of connective tissues there. So normally we never advise anybody to start releasing the thoracolumbar fascia because it is highly invested with the connective tissue, highly stiff, with a lot of sensory inputs. A patient cannot tolerate that pain. And there are many other approaches which we can indirectly release and relax the thoracolumbar fascia. And as you said, since the spiral line goes through the gluteal maximus and the gluteus medius through the thoracolumbar fascia, any release if you want to do will definitely work or affect the lower extremity and the trunk and the opposite upper extremity because of the spiral line.
From Jocelyn Villafoot, you said that stress will stimulate the postganglionic that causes vasoconstriction that leads to pain. So in order to relieve pain, which one will be better to use, cold therapy or hot therapy? Maybe this was the question you were reading earlier.
Yeah. I think I was reading. So I already said the answer. Cold actually stimulates the sympathetic fibers. When in the cold, we want to do the thermoprotection, we goes like this. So it is a sympathetic activity actually. So when it is in the heat, we want to dissipate more heat so that our thermal control will be better. So we will be open up. So in the facial perspective, hot will be better used than cold for relaxing the stress. So I think that also our practice also the same day. When somebody is under tension, we're putting the person under cold climate or cold exposure, his stress will more because of the vasoconstriction it produces. So it has to be open, it has to be thermal rather than cold. But that is a nice.
Sir,
thank you for that question.
Yes, we have 3 questions, sir, more.
Yeah.
One is from Vale. If you work on fascia for reintegrate due to any injury or adhesion, it requires more force and it will not be lasting only for few hours. How can we approach in this scenario? Maybe tomorrow he can get the answer.
Tomorrow. So we'll be just please attend tomorrow's session. That will exactly give you how the effects of the fascial techniques effects can be prolonged and why you are getting a short effect, because you are attaching on the fascia and its neurological structures, and after a while it will come back and the patient will be having. So there should be another way to approach to manage the facial. So tomorrow we'll be explaining on that.
And Nafis Attar asks, can lymphadenocytes can be reduced?
It's not reducing, it's like rechannelizing. So the fascia and superficial fascia and lymphatic system and adipocytes are the recent areas of focus on many of our facial researchers. So we can't say the word regenerated and all, but there is a channelization because superficial fascia is really very closely related to lymphatic systems and adipocyte system. So, and controlling or managing the superficial fascia is very easy. So many of the lymphedema therapists who is working in the facial research used to say that whatever lymphatic therapy you are doing is actually working on the fascia. And you have to look always on the fascia when you want a clear effect for your lymphatic channelization or such lymphatic procedures. So we don't have direct evidences. We didn't have any studies exactly on this area, but superficial fascia and lymphatic system relationship is well established. Yes.
So final question from Shantanu Malik. Which part of myofascial part is more injured, origin or insertional part of myofascia? I think this is
actually since the fascia is a continuous structure, it is origin from the cellular level winding around each and every region. We won't categorize the fascia as origin and in insertion. In fact, we used to say that most areas where your postural or everyday activity or your function is, for example, you are using any area which is repetitively under repetitive strain, or you are using a faulty posture where your fascia is more prone. So rather than we are using the word origin and insertion, we have to say that it is activity oriented. Fascia can mold and develop and improve and strengthen its capacity based on activities. At the same time, any faulty activities or prolongation or positioning and everything can change the facial structure. As I mentioned, fibroblast under conditions, it produces more connective tissues and elastin. Under bad condition, it will change itself into myofibroblast and starting the pathological fibrosis. So according to the situation where your body is exposed, your fascia and the fascial cells will start changing its functionality. So it's something like microfacial things. We use many terminologies for that one, but there is no evidence for that one. So we are not, normally we won't present in such normal clinical presentations. Like a mechanotransduction and all, we used to explain all sort of things, but never we explain in clinical presentation because there is no evidence for mechanotransduction and the changing of the fibroblast into myofibroblast.
Sir, one final question, sir, from Harshad. How to differentiate fascia problem from other musculoskeletal issues?
Why you want to differentiate? Actually, I will ask back. See, when you can see the body as a holistic system, there is the best way to find out things, and there is the best way to get the solutions. Our body is created as a full system. We, for our sake of identity and easy for study, we started developing musculoskeletal system, integumentary system, this and that and all. In fact, actually, there is nothing like that. So the fascia is the representative of the holism of the bone. So when you know that exactly how to trace the pain and what are the causative factor of the pain, what are the activities which produces the pain, and what is we can trace about what type of activity is causing the pain and how long and what type of pathological changes happen to the fascia and the muscular system and how much incoordination is making. I think that is the area where we'll be focusing more on rather than like we'll be telling about how to differentiate. So there is no differentiation actually. All the MSK problems are fascial problems, or the facial problems are MSK problems too also. That is why you use the word osteomyofascial.
Thank you, sir. Thank you so much. It was
mainly, I think it was a very productive Q&A session. Yeah.
Yes, sir. Yes, sir. And I thank all the participants who enthusiastically putting so many questions. There are few more questions asking about courses and all those things that we will be talking about it tomorrow. At the end.
Yes, exactly.
There are few programs also we are planning along with sir. Maybe after 3 or 4 months it will happen in India. Maybe that one will be an international one. And
yes,
we will reveal it at the right time. I thank you very much for politely answering all the questions, sir.
It's always a pleasure, answering questions is also a pleasure. Actually, my son is crying outside because I told him at 6 o'clock I will take him out. Okay. But the questions are very nice, very interesting. The question clearly mentioned that all participants listened the presentation very carefully, even though there was a lot of information in the presentation. So that's actually quite amazing.
Yes, sir. So we will meet on tomorrow at 7 p.m. Sir.
Thank you all. Thank you. See you tomorrow.
Thank you, sir. Thank you. Good night. Good night, all.